Hello, everyone, and welcome to today's webinar, Trauma Verification September Q&A Web Conference. Before we get started, I'd like to go over a few items so you know how to participate best in today's events. If you have joined the presentation using your computer's speaker system by default, it is preferred for optimum sound quality that you join via telephone. Just select telephone in the audio pane and the dial-in information will be displayed. I would now like to introduce Molly Lozada, Trauma Verification Program Manager. Molly?
Hello, everyone. Thank you for joining today's Q&A webinar session. I'm going to introduce myself, Molly Lozada, Trauma Program Manager, and Rachel Sanchez, who is the Site Visit Coordinator. Just a few housekeeping items we're going to go through for the first few minutes. Continuing education, to qualify for CE, you must attend at least 50 minutes of the educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim those. If at any time during the presentation you have any questions, please email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. Furthermore, understand the process and standards involved in an ACS trauma verification site visit and how following these will positively impact the quality of care of the injured patient at your facility. So with that, we're going to go ahead and get started. For anyone who's new to our webinar, if you have a copy of the resources manual or a PDF copy, please, you may have that readily available. In conjunction with the manual, you want to make sure that you are also using the clarification document and the verification change log, and both documents along with the copy or a PDF copy of the resources manual can be located at the link noted below on the resources webpage. So clarification and verification document updates are done monthly. I just sent one out about a week ago. If you were not on that mail list, you can email us and we'll add you to your hospital's profile. The documents are updated on a monthly basis. There are times where there may not be any changes to any of the clarification or change log, but I just wanted to let you know that any changes to criteria will be outlined in the change log and any clarifications will be contained within the clarification document. And we are going to go ahead and stream those a little better in the next couple of months, where you're only going to see clarifications that have a clarification and not necessarily have a document that's 88 pages long. So again, we're just going to stream those a little better going forward. These are just pictures of what they look like. They are a little different from each other. The clarification document, again, it's about 88 pages long, and we're going to go ahead and clean that up a little bit more. The verification change log, that is an Excel file, and you can filter that as you like, so that will not be changed in any manner. Again, you can just filter that and make it shorter for your level. Recordings of the webinar will be available. So the webinars are recorded during the session and will be posted within 1 week of the ACS on the ACS YouTube channel. So you can go ahead and visit our webpage here in the resources webpage. And you can find all our sessions from June of last year through current towards the bottom of the web page. All questions are pulled directly from the questions submitted. There have been no edits made to the content. If your question is not answered today, the question may require more information and will receive a response from the ACS staff within a week after the webinar. In some situations, if your specific question is not on the slide, it's because there may be a similar question and have the same response. Just a few announcements. The next verification Q&A webinar will be held Thursday, October 19th, 2017. And the deadline to submit questions will be Friday, October 6th, 2017. And the webinar time is different for next month. It's going to be from 11 to noon Central Standard Time. I know it says PM there, so it's 11 a.m. to 12 p.m. Central Standard Time. So just want to point that out to some folks. So I'm going to go ahead and introduce Rachel.
Good afternoon, everyone. So we have the 2017 TQIP Annual Scientific Meeting and Training coming up November 11th through the 13th at the Hilton Chicago. Registration is currently open. The guest rooms at the Hilton Hotel are filling up fast and are very limited at this time. So an additional hotel was added for the TQIP meeting. It's the Blackstone Hotel, and it's located right across the street from the Hilton Chicago, which is the TQIP host hotel. So the ACS group rate is the same, and the reservation deadline is October 9th. And you'll find more information at the link listed. Also, just a reminder, there's a variety of pre-conference workshops in which you can sign up for, and you'll see some listed on the slide here, but you'll also find more detailed listing at that link.
So it's Molly again. So I'm just going to go over the revision process a little bit here. Again, for some new folks to our webinar presentation, we have a stakeholder public comment website, and this is an ongoing website, and it will be up and running for pretty much a long period of time. We're encouraging and strongly encouraging trauma centers to review and comment on any of the standards, and your input will help guide the revision process to modify, add, or retire some requirements. We do ask that if you are providing a recommendation to add, modify, or retire a standard, that you also provide some supportive documentation or literature to support your request. So I just put a grid together to demonstrate what chapters are currently going to be under revision. We started with Chapter 6, General Surgery, and that is completed, and it's going to go through a final approval process during Clinical Congress here in October. And once that is approved, then we'll probably have more information as to what the next course of action is. The next chapters are Chapter 7, 8, 9, 10, 15, and 19. The pediatric chapter has already begun with their revision process, so I've been involved in that as well. So that is currently under revision, and we have another couple of costs to go through before that it goes through its first pass of approval. Just some reminders, some resources for trauma program managers and trauma medical directors. We have the frequently asked document webpage, and again, that list will expand over time. And also we have our tutorial for becoming a verified trauma center, first steps that will guide trauma program managers or medical directors in our consultation and verification process. Again, that is located on the resources webpage. Some scheduling reminders that Rachel's going to cover.
Okay, so we are pleased to announce the opening of our new Trauma Quality Programs Participant Hub and Account Center. The Participant Hub is your new point of access for participation in the Trauma Quality Programs. From this Participant Hub, you will access the Account Center to manage facility and contact information and request a verification site visit if desired. TQIP participants will also be able to access TQIP training materials from the Account Center. To get started, please view the Account Center tutorials located in the Training Resources section of the Participant Hub. And also feel free, if you have any questions, you can email traumaquality@facs.org. Site visit application. Just a reminder, the applications for your site visit must be received in our office 13 to 14 months before your visit. This holds your spot for the visit and also gives you plenty of time to prepare for the visit and complete the online PRQ. At this time, we are completely booked through October 2018. And we could actually start accepting applications in November.
So a couple of things that should be submitted with the application. Again, it's the orthopedic trauma leader form, which is available on site, and this is for level 1 trauma centers and those level 1 and level 2 combined trauma programs. So we do need that OTL form. For combined centers, that being a level 1 adult and a level center, they have separate visits scheduled or possibly scheduled on the same day, but share the same OTL leader. The form must be completed entirely for the first visit, and for the second visit, we only ask that questions 1, 2, and 3 are completed. Again, the form is located at the link noted before on the site visit packet website. For alternate pathway criteria, we've had several questions regarding the alternate pathway, and hopefully I've covered the questions throughout the webinar. There's a couple of other spots that this was going to come up. So what the alternate pathway is, just to clarify, it's a process by which the trauma center has non-U.S. or Canadian board certified or eligible physicians or surgeons who trained overseas. So these are members on your trauma panel, or possibly members that you want on your trauma panel who did not train here in the United States and are not board certified here in the United States. So this is a way for them to become active in your trauma panel. And what we ask for starting off is that when you are completing the application, that you note that applicant's name and their specialty, and forward a copy of the curriculum vitae with the application. In some instances, trauma program managers may not know at the time of submitting the application, so we do ask that as soon as you find out that you have a non-boarded U.S. trained physician on your panel, to contact Rachel as soon as possible, because that may impact the scheduling process. As it says here, an on-site evaluation by a member of the same specialty will need to be secured with the team, and typically those specialty members are and their schedules are very complex and very busy, so we have to work with them along with the other members on the team. So during the on-site evaluation for these non-board surgeons, physicians, they will be assessed by the alternate pathway criteria, which we call the APC process. There are 8 elements to that, and it is listed on the site visit packet and also on the resources webpage. That includes ATLS, CME, meeting attendance, being members of regional and national trauma conferences and attending those conferences, and also their cases will be reviewed during the site visit process by the specialty reviewer that comes with the team, and that's what their role is going to be, is to primarily focus on the alternate pathway applicant. There has been some changes, and I'll cover that in the next few slides. Those previously approved by way of the alternate pathway are not required to have an on-site review by a specialist, meaning that you would not be required to have an additional reviewer come along. What we expect is that those previously approved meet or adhere to the 8 elements of the alternate pathway criteria. Again, those are outlined in the webpage as well. The APC process is not applicable to U.S. or Canadian residency trained physicians or surgeons. So what that means is that if you have any panel members on your trauma center that did complete a residency in the U.S. or in Canada, and for whatever reason never became board certified, this would not, the alternate pathway would not be applicable to them. Just a little quick history on the SACS, because this is a change going forward. So in 1990, the VRC grandfathered or granted some members who were not U.S. or Canadian boarded to use FACS in lieu of board certification. So they were allowed to continue taking trauma calls. They were a fellow of the American College of Surgeons. Now, this exception was really a way to get those folks on your trauma call panel, but this will now go away in the next, over the course of next year and possibly in the next revision of the resources manual. So again, for those of you that are undergoing a site visit, just keep this in mind. So beginning January 1st, 2017 of this year, all non-US or Canadian residency trained surgeons who have not yet been inducted as a fellow of the college will be required to undergo a review by way of the alternate pathway. So they are going to be subjected to this on-site alternate pathway review. Surgeons who were inducted as a fellow of the American College of Surgeons prior to 2017, they're going to be grandfathered in. They're not going to be required to go through the alternate pathway. So again, if you have any panel members on your call panel, you want to notify Rachel as early as possible so that she can go ahead and get that secured.
Pre-review questionnaire, online access. When your application is received in our office, you will get an email receipt and your PRQ logins will be in the context of that email. So you'll want to hold on to that email. The online PRQ can be accessed at that link, and also a copy of the PRQ in Word can be downloaded from the link listed. We ask that you please do not submit payment with your application because your center will receive an invoice approximately 60 days before your scheduled site visit. This will include the annual fee for re-verification and TQIP. The annual fee does not include fees for additional reviewers if needed. At the link below, there's a really great fee structure with the fees for the next 3 years, and we encourage you to view it. Scheduling site visits. You should receive your site visit confirmation email by at least 90 days before your scheduled visit, give or take, and ideally all visits will occur during your requested time frame. As a lead reviewer is available for your site visit, we'll first contact the trauma program manager to confirm the dates prior to finalizing the visit. We strive to get your dates much earlier than before you receive your confirmation email so you and your team can prepare accordingly. Site visit preparation with reviewers. Reviewers will book their own flights through the ACS travel agent, and they do this approximately 30 to 20 days before the site visit. The hospital is responsible for the site reviewer's hotel accommodations as well as their ground transportation. The reviewer's contact information will be provided in the confirmation email once the full team has been secured, approximately 90 days before the visit. Please be sure to contact the reviewers directly within 30 days of the site visit to email their hotel confirmations, to get their flight itineraries and coordinate ground transportation to and from the airport and hotel, and any other site logistics.
So we're going to go ahead and move on with general questions. Again, here's a slide about the alternate pathway criteria for, and this is a little different. This is for the pediatric trauma medical director. And this is a change from what's noted in the resources manual. So please take a look at the clarification document for further information. But the question is, would you please review in detail the alternate pathway for pediatric trauma medical director eligibility steps and whether or not we need to register an alternative pathway formally with the ACS in order for them to be official? So to answer the many questions in this one slide, for anyone that is undergoing review by way of the alternate pathway, and again, this is for anyone, including the pediatric trauma medical director, it must be noted on the site visit application, or if you've already sent the application in, you need to notify ACS well in advance of the site visit, meaning you have to let Rachel know that you have someone that is going to pursue this process. For level 1 and 2 pediatric trauma centers, if the pediatric trauma medical director is board certified in general surgery, but not board certified in pediatric surgery, she or he must meet the pediatric alternate pathway criteria at the time of the site visit. So let me clarify this a little further. For a level 1 and 2 pediatric trauma center, regardless if they're board certified in pediatric surgery, they must be board certified in general surgery. So I just want to make sure that was clear. So here are the criteria for the alternate pathway for the pediatric trauma medical director. And again, this is noted in the clarification document as well. There's 6 elements to this. In addition to notifying the ACS that you have this process will be done, is be credentialed by the hospital to provide pediatric trauma care, be a member of the adult trauma panel, participate in trauma call, accrue an average of 16 hours annually or 48 hours in 3 years of verifiable external CME, which at least 12 of those hours during the 3 years must be related to clinical pediatric trauma care. These are basically what's on this list is essentially what the pediatric service needs to meet in addition to. So be current in PALS or have taken the Society of Critical Care Medical and Fundamentals of Pediatric Critical Care course, and develop a formal relationship with a pediatric trauma medical director at another verified level 1 or 2 pediatric trauma center. So really the formal relationship is that they know someone at a neighboring verified pediatric trauma center that they can kind of work with in the event that they need to discuss a case. So really that's the formal relationship we're looking for, that they are able to reach out to these other programs. So question on how many months do we need on-call schedules for trauma, orthopedics, neurosurgery, 3 years from survey? This is a great question. It's actually come up several times in the last month or so. So we're not looking at 3 years of data. The only time we look at 3 years of data is for the CME requirement, and board certification obviously has to be current. So for centers undergoing a site review for either consultation, verification, or re-verification visit, it is required to have the on-call schedule and backup call schedule, if applicable, if you are using a backup call schedule, for the reporting year. So we're only going to look at that reporting year, so it's going to be 12 months. Great question again. I see no specific standard or CD related to providing feedback to EMS. Why was it mentioned as a requirement at the last webinar? I do want to clarify that it was not stated that it was a requirement. I think the intent is that it's essential, it would be an essential responsibility for the tertiary facility to provide specific feedback to referring facilities and pre-hospital providers. The feedback should include final diagnosis and general course and outcome of the patient and any PI issues that were identified. So again, it's not a requirement. There's no CD tied to this. It's more of a best practice, if you will, if you want to call it that it would be very beneficial for this communication to go back to the EMS and vice versa. There's no standard in the Orange Book relating to the use of an electronic version of the EHR, so why does ACS have a stance? Again, for clarification, this is not a requirement. There's no CD tied to this, but again, for best practices, use of the electronic flow sheet must contemporaneously document the care of the patient, and that's what we're really looking for, and looking at the EMR or the EHR at your facility. As I stated before, typically, and there's some programming involved in this, typically the electronic flow sheet denotes the date when a key entry is made. Therefore, you must be cognizant of the date time stamp. So if reviewers see a number of instances where the date and time is not accurately documented, they may recommend to revert back to the paper flow sheet. And I put in here applicable because some centers probably never had a flow sheet, a paper flow sheet. So again, it's just something to be cognizant of when you're documenting in the EMR or the EHR, as some people call it. Question about OnSite: what is the process for a focused review as far as the PRQ cases and dates? So for an OnSite focused review, the following are not required, which is a PRQ. You do not have to complete another PRQ. There's no pre-review dinner, and there is no facility tour. A site visit application must be submitted shortly after receiving the verification letter. This way you can get your visit scheduled. The visit must take place on or before the date noted in the letter, which is typically a year from the initial site visit date. So again, as soon as you receive your letter and it's asking for an on-site focus review, you want to go ahead and submit your application as early as possible, so that way Rachel can go ahead and get started on that process. During the on-site focus review, we ask, there's going to usually be a block of 5 hours, anywhere between 4 to 5 hours, for reviewers to review medical charts, and that it's going to be a limited quantity, because obviously some centers may wait till they receive the report to start implementing changes to their process. So during the on-site focus review, we do want the trauma center to only pull cases commencing with the changes that have impacted the deficiencies identified. So the schedule for the on-site focus review is, as I mentioned before, typically done within 5 hours. It's a one-day process, half a day of a process with 2 surgeons. One of the initial reviewers may return. They typically do return, and oftentimes due to various scheduling challenges, Rachel may schedule a nurse to go with the surgeon reviewer. So don't be surprised if you see a nurse coming to survey on the focus review. We do ask for a corrective action plan approximately 30 days before the scheduled site visit date. The plan does not have to be in great detail. We do ask that it provides a summary of the deficiencies and how those weaknesses may be addressed. In some instances, some of them can be addressed prior to the focus review. In some instances, they may take a little longer. You may have a presentation during the focus review. It's not required, but if you want to have a presentation, that is acceptable. And again, because it's a one-day review, typically reviewers like to come in the night before the focus review, so they will start at 700 or 0700 hours, unless you hear otherwise from the office or from the site reviewers based on travel. If they do come in the day of the site visit, they will travel the morning of and possibly start about noon. So, but again, typically they will arrive the night before, and they will require a hotel room for that. Again, for on-site visits, on-site focus reviews, we are there to look at your chart review process and validate what those corrective actions were. There is a closed meeting with the reviewers, so if there's an opportunity to address any concerns, you may have that at that time. And again, there's an exit interview, and the exit interview does not have to be large. It could be very small based on whomever your trauma medical director would like to invite. So I had a question about the OPPE and whether or not we had some examples. So we do have some examples. There's a couple on the website, and then this is one that we've received recently that it's pretty much what we've been telling trauma centers that they can use. And again, you can design the OPP form as at your institution, what works best for your institution. I think ideally what our intent behind this is that it captures pretty much a lot of the elements or a lot of the requirements that we asked trauma surgeons and your trauma panel members to meet, such as CME, peer review, are they credentialed, do they have privileges at your trauma center? You can have a slew of information on this document, or keep it very basic. This is a very basic one. You can have it as you like. This one was a little confusing to me. It says a level 1 facility Is it a critical deficiency if trauma EMS outreach is housed within centralized outreach department rather than trauma department? Is it a critical deficiency if no EMS liaison but trauma outreach filling that role for EMS? And what was confusing to me is it started off as a level 1 facility, and then it says it's a level 2 from a level 2 facility. So, but it doesn't really play a role in the response because a level 1 and level 2 are equivalent. So for the first question, and again, if I did not answer this correctly, please, whoever submitted this question, reach out to me. For the first question, it is not a critical deficiency if trauma EMS outreach is housed within a centralized outreach department rather than in under trauma. With that said, there must be a direct link or resources dedicated to trauma outreach programs. So there has to be some connection there. It can't just be outreach somewhere else and not have trauma involved, but there has to be a link there. And what I also want to clarify, when someone says critical deficiency, to me, that really means as a type 1. These are not type 1 deficiencies, so I just want to make sure that I clarify that. The criteria does not state, so for the second question, the criteria does not state that it must be an EMS liaison per se. However, there must be a representative from the emergency department that participates in the pre-hospital PIPS program. So if you want to designate that emergency department rep as your EMS liaison, that's fine, but we don't necessarily say in the book it has to be an EMS liaison. We're just asking that someone participates with EMS from your emergency department. PRQ question about FAST. So can you please give an example of the FAST exam competency requirements for a level 2? So I just want to clarify there are no CDs or requirements regarding FAST exams. There is a question in the PRQ that asks to describe the QI or /PI process for FAST exams at your facility. So you can go ahead and describe what that process looks like at your facility, but please note that that does not, depending on how you answer that or based on how you answer that, it does not infer that a deficiency or criterion deficiency will be cited if you don't put anything in there, but we do want you to state how you conduct those processes, that exam at your facility. PRQ, examples of loop closure for system issues. So someone asked, could you help give examples for the PRQ where they are requesting 2 examples of loop closures for a system issue? So I provided several on here, and obviously there can be an abundance of issues, and these again are just some examples of what we've seen over time that are pretty much common practice maybe. I don't know, it just depends on where your facility is. So you have prolonged transfer times from regional facility, prolonged EMS scene times for ISS greater than 15, ED nursing inadequate use of rapid infuser, inconsistent CT tech staffing, OR delays in obtaining blood products, anticoagulant reversal ×2 head CT, and so forth. So again, I just want to make sure I provided some examples, and you're not limited to what's being displayed here. You can actually add more to this if you like. When's the right time during admission to screen for PTSD? PsyCare said that everyone will be positive is screened within 30 days. We've developed a tool for PTSD to screen all trauma patients within the admission stay, and if positive, it referred to psych boxes checked off. Some centers said that it's the provider's discretion to screen for PTSD, is it? So busy slide, so I just want to hopefully clarify as much as I can on this one. So I just want to say we don't currently have any standards on PTSD. There is a section in the book that discusses and goes over PTSD, and it's possible that we may have some standards in the next revision of the chapter, but currently there are no standards. The VRC stands on PTSD is that the trauma center should develop guidelines internally, meaning at your own facility, regarding the evaluation and treatment and management of those patients. So you can go ahead and establish that process within your own facility. Inclusion criteria. Is it required to include patients greater than 65 years of age with same level fall and isolated hip fracture and registry? Again, this question kind of comes up every webinar, and you know, we don't have any guidelines on this. As it states here, the admission policy for elderly patients with single level falls or isolated hip fractures will be established by the individual trauma center. So if these patients meet the NTDS inclusion criteria, we say they should be captured in your trauma registry, but I do know that there are some states out there that don't want you to capture that, and that's totally up to your policy, your practice. But if you do capture that information in your trauma registry, and you're going to use that, you know, those patients to complete your PRQ and use it for your volume requirements, we do ask that you do follow the process outlined for non-surgical admissions on page 121. Again, it's acceptable to have a process where you do capture these patients, or if you don't capture those patients, that's going to be set by your admission policy. ICU physician response. What suggestions do you have to capture the trauma surgeon's response to the ICU within 15 minutes of being called? So I took this to mean what kind of documentation or how they should be documenting that information. And again, if I'm not answering this question correctly, please reach out to me. So some centers do it a little differently than others. Obviously, some centers, you know, if they have a bag scanner, that's ideal because you can run a report based on that. But basically what some centers do, they just kind of document that on the patient's chart, if that's where they're documenting that information, and that can be captured by the nurse or self-report. You know, if someone else has some suggestions that they can share for best practices, I'm happy to accept those for the next webinar, if you'd like to submit those to the cotvrc@facs.org. Is the trauma backup surgeon required to be within 15 minutes of the hospital and held to the same response time for the high level of activation? So the answer to this is no. So if the primary attending is tied up on another trauma case or in the OR with a trauma patient and the backup trauma surgeon is activated, the ACS has not mandated a response time for that surgeon. The institution should monitor response time through the PIPS process to ensure delays do not impact patient care. Ideally, you want to make sure that if you have a trauma activation come in, it's a high, you know, a TT1, a high alert activation. Ideally, you want to see somebody there within the 15 minutes, but we don't have standards at this point in time. So we're going to go ahead and move on to CD-related questions. Does the ACS take a specific position on the admission of trauma patients to an ED OBS unit? Would this be considered a non-surgical admission, and are there specific PI review ramifications? So for verification purposes, and this is again for completing the PRQ as well, patients who do not meet the NTDS trauma inclusion criteria and or are discharged within 23 hours, meaning they're kept just for OBS, do not count towards the trauma patient admission total or volume requirement in the PRQ, and would not fall under the and these also would not fall under the non-surgical admission category because they weren't admitted. So again, OBS patients, we don't use them for verification purposes. You can capture them in your registry. That's perfectly acceptable, but they cannot be used to complete the PRQ and meeting any of the volume requirements or completing any of the data tables. I had a question about over and under. Is there an exact formula to calculate over and under triage? So I have a formula, or actually just a template really, and again, you can develop your own template for this, but you can certainly use the one that's on the next slide. So I just wanted to give some numbers out on OverTriage, what's acceptable and what's ideal. So for OverTriage, minimally injured patients taken to the highest level of care, so anywhere between 25 and 35% are acceptable. Under triage, which are severely injured patients taken to a lower level of care, the optimal goal, which we have a standard for, is less than 5%, which is CD3-3. And here is the method that you can use. And again, you can develop your own metric. This is just one that I guess some centers use. It's pretty, it seems simple enough, but again, you can develop your own. So as you can see here, for the full highest ISS 1 through 15, if you have 10, you're going to get 10 over 30, you're going to get 33% over triage, and the same for the limited. And again, you can use this table to then gauge your activation criteria and base and update as you see fit based on what those numbers are. And again, this is just an example. You can use whichever method works for your facility. Commitment letters, there's in the book, there's a section on commitment letters, and the question is, does this require signatures from all department chiefs, or is the signature from the CMO and department chairs adequate? Does a hospital with adult and pediatric program need a separate signed commitment letters for each, or can one letter cover both? So the commitment letters may be signed if authorized by the CMO and chairs for all the departments. I mean, in the book, it does talk about the governing bodies. So if your CMO is authorized to do so, they can go ahead and sign those letters. As far as for adult and pediatric programs at the one facility, or even if they're under the same auspice of a trauma center, you can have one letter that includes both the adult and pediatric programs. Non-surgical, is it a deficiency to have greater than 10% non-surgical admissions if all are appropriate with low ISS and have been PI'd? So no. So again, I just want to clarify that having greater than 10% of non-surgical admissions does not mean you're going to get cited for a deficiency. Where the deficiency comes in is if you do have greater than 10% non-surgical admissions and the center does not review those cases through the PIPS program, that's what's going to trigger the deficiency. But if you do have greater than 10%, I mean, we've seen it as high as 50% for some centers, only because they have an elderly population in their region, and that's what they see, majority of. So if you have 50%, that's fine, as long as you're reviewing those cases through your PIPS process for appropriateness of care. So again, the CD is not having 10%, greater than 10%. Question on who all needs to have or be current in ATLS. Do PAs, NPs need ATLS certification? PGY 1, 2, and 3 need ATLS certified. So I've kind of provided, and what I may do for the next webinars, maybe put this in a table, but I wanted to just be clear on who needs ATLS currently versus at once or had it once before. So the trauma medical director must be current. Trauma surgeons must have successfully completed it at least once. Physicians board certified or board eligible in emergency medicine must have successfully completed it at least once. Physicians board certified or board eligible in specialties other than emergency medicine, such as family practice, internal medicine, etc. And these physicians provide care to trauma patients in the ED. The difference between whether they're board certified in emergency medicine and board certified in family practice or internal medicine, etc. So please pay attention to that. For advanced practice providers, NPs, we call them mid-levels in the book, but they're advanced practice providers who are members of the trauma team activation, and they participate, evaluate, and resuscitate trauma patients. They must be current, and that is not necessarily a change, but there is clarification in the clarification document regarding that. Are there any examples? Are there any other examples of approved contingency plans aside from the published backup neurosurgery cost schedule for CD8-3? So there is. So the table that you see displayed here is in the clarification document. It's about, I don't know, towards the end of the document, maybe 3 pages from the last page of the document. And it's a great table. So, so if you don't have a contingency plan, then you have to have a backup cost schedule, or a backup cost. If you don't want to have a backup cost schedule, then you need to have this contingency plan that, you know, outlines who's going to be your, who's going to cover emergency coverage, initial evaluation, your backup, etc. So here are some guidelines of what that may look like. So for initial eval, you can have a neurosurgeon, a senior resident, a trauma surgeon, EM physician, or your advanced practice provider. For backup, you can have your contingency plan that has a neurosurgeon, senior neurosurgeon, resident transfer agreement, etc. So again, this is in the clarification document, so you can use this. You can utilize this for your trauma center. Board certification for anesthesiologists is all anesthesiologists have to be board certified. No. So the answer is no, they do not. We are only asking for the anesthesiologist liaison to be U.S. or Canadian board certified or board eligible. So if you have, I don't know, I've seen a center that had 20 anesthesiologists and only one of them was board certified, that person was the liaison, that is acceptable. And again, this is a change from what's noted in the resources manual, and it is noted in the clarification document and change log. Radiologist, can fellows residents provide for the 30-minute radiologist response requirements for interpretation and or intervention? So as only an IR trained radiologist can do the procedure, it is the IR radiologist that must be present. Now, if your institution credentials fellows to independently perform an angiogram embolization, or at least to start it, then they can qualify for the 30-minute rule. So I just wanted to clarify that. Can the trauma director also be the SICU director? And if so, who will be the liaison for critical care at peer review meetings? So for level 1 adult trauma center or pediatric trauma center, the trauma medical director may also be the ICU liaison. Since the role will be served by the same person, she or he will meet the requirements for the trauma medical director and ICU at the trauma peer review committee meeting, meaning that if your trauma medical director, so in the PRQ, what you're going to do is you're going to respond the same number for both these slots. So trauma medical director participated 100%, then that would be true for the ICU director because they're serving the same role. Now, I do want to clarify, for a level 1 adult trauma center, if the TMD will serve both roles, she or he must be board certified in surgical critical care. So that may impact how, whether or not your trauma medical director is going to serve both capacities, because if they're not board certified in surgical critical care at your level 1 facility, they cannot also be the ICU director. So again, that is for a level 1 adult trauma center. In some instances, the trauma medical director may also appoint a predetermined ICU designee to attend the trauma peer review committee meeting as the ICU representative if there is some kind of conflict there. Regarding surgical specialists, our level 1 center is required to have 24/7 coverage for microvascular in relation to above question. Can there be a transfer agreement as indicated in 8-5? So to clarify, a level 1 and 2 trauma center must have microvascular capabilities. So if you don't have a microvascular surgeon, you have to have the capabilities. And what that may look like is you may have a surgeon, or you can satisfy this requirement by having a surgeon who can use an operating microscope for nerve repair, free tissue transfer, etc. So you can have someone do that. So these specialists are not required to be in-house 24/7, but they must be available in person to consult when requested by the attending surgeon. So, and then the center can have a transfer agreement in place for those complex injuries that the trauma center is not able to manage. Trauma registrar. For the trauma registrars, where the number of transcriptions be updated from the current 500 to 750 to reflect current requirements. At this time, there are no revisions to update the number of the transcriptions cases. As I mentioned earlier in the webinar, this is going to be one of the chapters that we are going to be revising within the next 6 months, if not 3 months, definitely within the next 6 months. So I highly urge you to visit the public comment website, the stakeholder public comment website, to provide feedback on if you want to see that number increase, you want to see a decrease, whatever your concern for that is. We want to hear or get that feedback so that way we can use it in our revision process and make those changes. So again, no changes right now, but we are currently looking at that chapter for revisions. Prevention activities. For injury prevention, should the major mechanisms of injury be developed from the trauma center's registry, epidemiology statistics for specific counties, or a combination of both? It should be a combination of all. So for level 1, 2 trauma center, you must use your trauma registry and epidemiologic data to drive the center's injury prevention activities. The program and intervention strategy should then be selected based on that data. So you definitely should use one or the other, or a combination of both, whatever works for your facility. Research. Does there need to be a trauma surgeon as an author or co-author in all of the 20 research articles? Manuscripts are as a result of a multi-center study. Do all contributing centers get to count the manuscript as part of their 20? If going the alternate route for research, are only scholarly activities of trauma surgeons allowed? Several questions, and hopefully I've answered this in this slide. And then in the following slide, there is a table that you can also find on pages 144 through 146, which goes into a little bit more detail. But I just wanted to point out some important items of this. So of the 20 research articles, at least one must be authored or co-authored by members of the general surgery trauma team. So, again, at least one must be authored or co-authored by members of the general surgery trauma team. For multi-center research articles, if the authors contributed to that multi-center article and they are listed as an author, it will count for all trauma centers. For the 7 scholarly activities, it may include members of other disciplines for trauma. It does have to be related to trauma, but it can include other members from other disciplines. I also want to make clear that case reports are not acceptable as to use for the 20 research articles. Again, please refer to pages 144, 146 of the resources manual. And again, this is the table that it's a one-stop shopping, and it kind of tells you exactly what you need. What's not on here is that we will accept acute care articles, and that is noted in the clarification document. We're going to move on to CME. I have a couple of questions for CME. 33 hours CME from board certification counts as external trauma CME. Does that include any pediatric trauma CME? Yes. So if they're peds boarded or are going for their general trauma and there's some peds CME or peds questions in their MOC or through their board certification process, absolutely they will count for pediatric trauma CME. How many CMEs are brand new EDMDs supposed to accrue when they are board eligible but have not taken boards yet? A little tricky question, and again, on the surface, I responded that this would be based on their date of hire and or completion of residency. Again, this will vary based on some information that I would need to answer this more in line with what you're may be asking. So for new members on the service and present for the reporting year or longer, the expectation is that they accrue 16 hours of CME annually. So if they've been there for a year and a half, they're expected to have 16 for the first year and 8 for the next, or a total of 24, however they've accumulated that. Providers who are board eligible are not exempt from meeting the CME requirements, so they must meet the CME requirements. External CME, if your facility provides CME for quality, meetings, grand rounds, etc., and the CME program is accredited by an external body, do these activities and hours count as external CME, or where they only count towards internal education process hours? These types of conferences and meetings are considered internal trauma CME and are acceptable to use for the non-liaison. So they're not technically external trauma, they're internal trauma. If you are changing from an ACS Verified Level 3 to an ACS Verified Level 2, what is the expectation for CME requirements? I thought this was a great question. The expectation would be that the trauma center must be in compliance with the CME requirements. There are no CME exemptions or proration for trauma centers that are currently verified as a Level 3 and are moving towards Level 2 verification. They will be held to the same standards. Excuse me. Alternate liaisons. Do alternate liaisons from the same CME requirements of 16 external a year? So my understanding is by alternate liaison, I'm going to assume this means a predetermined designee at the trauma peer review meeting. If that's correct, the alternate liaison is required to meet the CME requirements through any of the following or a combination of external trauma-related CME, internal trauma CME, or through an internal education process. So they're not subjected to just do external trauma CME. They can do it through any of these forms or a combination of these forms. Self-assessment, question on whether or not physicians who are participating in their MOC and are doing a self-assessment, is that in addition to the 33 hours that it's acceptable, or is it part of the 33 hours? So self-assessment tests for initial boards or board recertification are part of the 33 hours that is permitted, so it's included as part of that. Tracking on PRQ, when tracking CMEs, if an ER physician left the organization, do we need to include them in the report? You do not. If the provider was present during the reporting year and is no longer at the institution or on the trauma call panel at the time of the site visit, do not include their information on the PRQ. If you list them on the PRQ, what's going to happen is, and they're short, they left mid-year, and you list them, they're not going to be compliant with the standards. So what's going to happen, it's going to result in a deficiency. So, so we ask that you do not list anyone who is no longer on your trauma panel. Does average of 16 hours CME annually still mean must have 48 in 3 years, or is close to 16 average per year? Is it an absolute number of hours? The trauma medical director and liaisons must accrue a total of 48 hours of external trauma-related CMEs over a period of 3 years leading up to the site visit. It would not be based on the calendar year or by an absolute number of 16 hours. So if you have someone who is trying to meet the number of CMEs and they did 16 the first year and then maybe 8 the second year and now has to complete the balance the third year, they can do it all in that 1 year. So it's a rolling year. It's not an absolute number that you have to do 16. We just kind of broke it up as 16 hours annually. So that concludes today's webinar, and I'd like to thank everyone for participating in the session. Thank you.
Thank you again, Trauma Verification staff, and thanks to everyone for attending today's webinar, Trauma Verification September Q&A Web Conference. If you have any other questions, please contact coTVRC@facs.org. On behalf of Trauma Verification and all of our presenters, thank you so much for joining us today, and have a great rest of your day.